It's a minute through YouTube.
A very happy new year to all of you. And today I will be discussing lasers. We all have been hearing about laser in proctology for long, but always we have got a mixed signal. Whether it is useful or not, what is the success rate, what are the complications. Actually, lasers are being done in Kolkata from the year say 2019, just before COVID started. Lasers were introduced in Kolkata. Worldwide, lasers is being done from 2015. So I was very scared of lasers because in just post-COVID era, I got many patients with large burns in the gluteal area after these laser surgeries. Laser done for fissure landed in a big fistula. So basically that gave me a big scare, and I stayed away from laser for many years. But it's demand of the today's surgical practice. Patients come and say we want to get laser done. Initially, I used to send all my patients to my friend Dr. Kollankot, who started laser in Kolkata. He has been doing, and he claims that his results are very good. But few patients do come to us with failure and recurrence. So I went further for my training and experience to various places. Finally, I landed up in Jalandhar to a very good teacher, Dr. Kamal Gupta, who taught me how to use laser. Laser alone is not a very good tool. We have to learn what are the advantages of laser and how to use it. If we use it judiciously, it reduces the pain of the patient to a very large extent, and we can send back the patients to work very soon. So what we now do is a combination of procedures, what we call hybrid procedures, basically in all the procedures that we are doing except for in fissure. All other procedures we are doing a combination of open procedure and laser. So our idea basically is to reduce the suffering of the patient and something that he can go back to work very soon. So with that idea, basically my aim is shifting the paradigm from traditional surgery to minimally invasive surgery. So that is how we will proceed today. Today we use diode laser for this. Diode laser comes in different wavelengths, and different wavelengths have different uses. Initially we were using 920 nanometer of laser for proctology, but 920 nanometer of laser usually gets absorbed in the hemoglobin, but water absorption is not very good. Hence the results were not very good. Once we shifted to 1470 nanometer, the results are much better. And the ablation, the burning is very precise. Now we come to why laser. Laser is what? It's basically an energy source. Just like diathermy, we burn with laser. But in diathermy, the temperature minimum which reaches is more than 100 degrees Celsius. Here, the burning, same amount of burning will occur at the temperature of around say 60 to 70 degrees of Celsius. So the lateral damage is much less. So that is the basic advantage of laser. So what we do, we deliver the thermal energy precisely and to specific tissues without damaging the surrounding tissue. The surrounding tissue damage is much less. It's basically controlled structure, ablation and shrinkage, coagulation. So how does it translate to the patient? Less post-op pain, he returns back to work very fast, and what we dread, that is fecal incontinence, the chances of fecal incontinence is far less because the sphincter damage reduces. This is দেখা যাচ্ছে না? কি আমি আমার অবস্ট্রাকশন হচ্ছে? ঠিক আছে? This is a machine which we need for laser. This is a laser delivery machine basically. And those are the other paraphernalia which we need. Most of these are present in our OT except for the laser fibers which come with this machine. There are 3 types of fiber which we use for laser procedures. So we can only do laser where this machine is present. The aim of delivering this lecture here is to convince Dr. Mishra to get one for us here. And these are specific goggles which we need so that our eyes are damaged. There have been reported a few cases of retinal damage in surgeons who have not used these goggles. So it is always advisable to use these goggles by all who are present in the OT during the study. What are the diseases which we commonly address in proctology with this machine? The 4 common benign disease, that is hemorrhoids, anal fissure, fistula in ano, and pyronidal sinus. These 4 diseases are amenable to laser with this machine. But saying this, we always have to define and select our cases where laser will be useful. We cannot in blanket say that yes, we will use laser in all the cases. We cannot do that. In hemorrhoids, when we do a traditional surgery, that is a open hemorrhoidectomy, what we do? We excise the hemorrhoid, so leaving behind a lot of raw area. So that has 2 problems. One is pain. The post-operative pain to the patient lasts for around 3 weeks, and there is a big ulcer type of wound which needs dressing, and patient needs to stay at home with a heavy dressing behind. So it's very uncomfortable for the patient to carry on with that. But in laser, what we do? We don't cut anything. We do a plasty operation. We do a hemorrhoidoplasty. So laser alone, when it started, what we used to do was we used to try and burn the hemorrhoidal artery with the laser fiber, and then shrink the hemorrhoid with laser, coagulating the laser. But today we have refined after so many years of trial and error. Now we combine 2 procedures in all hemorrhoids primarily. One is that is suture ligation of the hemorrhoidal artery. We don't try to burn the hemorrhoidal artery with laser because that doesn't give a very 100% good result. Once we ligate the hemorrhoidal artery, the main source of hemorrhoid is cut off. That in itself, many surgeons like me, I used to say, why should we proceed with laser after that? Because we are taking care of the hemorrhoids with the suture. That in itself is one established procedure for hemorrhoids. But with this ligation alone, what happens? The pile mass stays as it is, and the patient is not satisfied because this pile mass will shrink, say, in around 3 to 4 months. So what we now add, we now shrink this pile mass by laser. We deliver laser energy in a controlled manner. The pile mass shrinks. So the patient is satisfied. Yes, my pile mass has gone away, and there is no further bleeding, and he gets through. So this is basically what we do. This is very good for grade 2 and grade 3 hemorrhoids. For grade 4 hemorrhoids, I would still not consider laser as a first line treatment. And at all, if you want to do a laser in grade 4, then you have to do a suture hemorrhoidoplasty first. What we call Chivate's procedure, or you use the stapler first, and then you can ligate. But usually we don't do. That's an overkill. If we do a Chivate's procedure very nicely, we don't need to do laser first. So grade 4, usually it should be avoided. What is the advantage? There are no open wounds, there is no cut. The patient has very minimal pain. He can go home the very next day, and he can go back to work in a day or two. There is some amount of irritation because of the burn that we give. So That is the only problem. There is no sphincter damage, there is no anal stenosis that we commonly see in open surgeries. This was a very long back history. There are no randomized data in India as of now. No one has done a very good study. Probably, I don't know, some studies might be going on. This is a 2018 study from USA where they showed that the symptom resolution is very good, but and basically second surgery rate is also very less. But in India, we still find that the second surgery rate is quite high. Even after 6 months, we have seen that recurrence has come back because there is no standardized teaching in India for this procedure. There is no institute who is giving standardized training to anyone so that the results will be standardized. Everyone is using his or her procedure. So that is why the results vary very long, very far away. Complications are very minor. Pain is very minimal. Yes, this perianal vein thrombosis can occur if the laser is not used very nicely. If we use lots of amount, the laser amount is more or less fixed. We should not give more than 150 joules per pile mass at a time. If we give a high dose of laser, then this perianal vein thrombosis can occur. Bleeding is very, very minimal. It occurs only if the laser is not handled properly. Burn lesion, yes, this is something which used to occur very frequently earlier because of the learning curve. But now we rarely see any further burn lesions. Eczema is one of the problems if we don't use ice post-operatively. Then eczema do occur. And severe complications which used to occur with open surgery like incontinence, necrosis, abscess or fistula formation are very, very few. Now, to start with, during the learning phase, yes, we have seen a few fistula cases which occurred after doing uteroplasty by using laser. This is how it is done basically. The machine is set to 6 or 8 watt in a pulse mode. This machine has 2 modes whereby it gives laser energy in pulse mode or in continuous mode. For piles we use pulse mode so that there is no continuous burn. The pile mass, the laser fiber is introduced from the mucocutaneous junction. So there is a small puncture wound which occurs at the mucocutaneous junction, and this pile mass is then burned with controlled laser in different directions. The whole of the pile mass is burned, basically, is coagulated. This video is not probably playing. I don't know. It's not, so we will avoid it. So that is about hemorrhoids. Next we come to fissure in ano. Fissure in ano is one of the most painful situations which come across, and the patient is in agonizing pain. And if we just can do a small sphincterotomy, the pain will subside. So we have all been doing a sphincterotomy in an open procedure using a knife so long. We can now do the same procedure using a laser. So the advantage of laser is basically there is no pain, there is no bleeding. These are the different stages of anal fissure. A small anal fissure in the first picture is there can be treated conservatively with painkillers, cyst bath and stool softeners. So once the sentinel pile is formed, then conservative treatment results will vary because it will take a long time for the patient to heal. If the patient is cooperating, you can still do conservative treatment in most of the patients. But if the patient is uncooperative, if he says his pain is very high, then we have to take him to surgery. In the surgery, we do sphincterotomy, and a few cases we might need to do a flap. Basically, lateral internal sphincterotomy is what we do in all cases. Now we have shifted, I have personally shifted to all my cases to laser because laser gives very fast, better results, and the patient can go back to work the next day. We can do this in a daycare procedure with procedural block. General anesthesia or spinal anesthesia is also not needed for these cases. What we do is we cut the internal sphincter. We need to cut only from the lower margin up to the dentate line. That is about 2 cm of internal sphincter has to be cut. That's all. And once we release the tension, the fissure will heal as the vascularity will increase. This same principle applies for open surgery also. This is an open sphincterotomy. You can see the internal sphincter, lower 2 cm of the internal sphincter has been lifted over the artery forceps, and this can be cut using a laser or it can be cut using a diathermy. The diathermy, the problem are two. One is sideways spread because the artery forceps is touching the skin. Once we touch the artery forceps with the diathermy, there will be a bump. But with laser, that problem doesn't arise. And the bleeding control, hemostasis control is much better with laser because it cuts very slowly. It cuts fiber by fiber, but diathermy will cut in one shot. So these are the advantages which I have already said. It can be done as daycare. Usually it is done as daycare. It relieves the pain immediately and minimal external wound. There is basically no external wound. Even this in open sphincterotomy, when we do, we just cut the skin with laser itself. About say 2 mm to 3 mm of skin is cut just to introduce a mosquito forceps, and then we can lift this. And we can go back to work very soon. Here we use bare fiber. There are 3 types. In hemorrhoids we have to use a conical fiber. Here we use a bare fiber with 10 to 12 watt of energy in a continuous mode. These are basically the machine settings which we have to see before proceeding to the procedure. The difference between the results of open and laser sphincterotomy is not much because the procedure is the same what we are doing in both. So the results are comparable. The only thing is the time taken for laser surgery is probably a few minutes less, and the pain is much less, and the return back to work is very fast. This is again not pain. So now we come to a major problem: fistula. Fistulas are a big problem to us and to the patient because they keep on recurring. The very high rate of recurrence is there. And we see fistulas, patient is suffering for years on years, and he has had 2 or 3 surgeries, but still he is not getting well. The major problem with fistula is what? Is to heal and to save the sphincter so that incontinence doesn't happen. So this is one place where laser gives a big advantage. In laser, when we are using laser, we don't cut the sphincter at all. So that is where there is a very big advantage of laser. So basically what I said, fistula is a very tightrope walking between curing the disease and preserving the sphincter muscle. If we want to, what we have done routinely till now, we have done a fistulectomy or a fistulotomy. Fistulectomy or fistulotomy means we take out the whole of the tract, disease tract. So we cut through the sphincter from the external opening to the internal opening. We cut everything out So that is a major tissue damage. There is a large wound and there is a lot of sphincter damage. So this is something which we avoid in fistula laser closure. In fistula laser closure, what we do is we just take care of. Initially, when we started, we just used to burn the fistula tract with laser and it used to close. But because the main disease was not addressed, which was in the anal canal, there was a very high rate of occurrence. So, as our learning improved, we have modified ourselves. Now, we address the central disease in an open procedure. That is, we take down the internal opening. We take down the anal gland from there and then either we can suture it or leave it open. There is a small wound, even if we leave it open, it doesn't matter. It will heal in around say 10 days. And this tract we burned up. Once the central disease is taken care of and we just close the tract by burning it out, then the whole tract will close down and it will not recur. The recurrence rate has come down drastically. What we used to get with fistulectomy, the same procedure, same results we are getting now with laser surgery. But yes, we have to combine. So what we do here, we use a 360 radial fibers. This is the third type of fiber. These are the three types of fiber we have to use in laser. One is conical, used for hemorrhoids, bare fiber for sphincterotomy, and 360-degree radial fibers. These are for fistulas and fibrosis. If you have to burn a tract, it has to, the energy has to go all 360 degrees. Then only the whole tract will be burned. So in this, we are not touching the sphincter at all. We are just going through the fistula tract and we are burning it out. So the sphincter itself is preserved. So what are the main indications of fistula? If it's a say very small fistula with a straight tract, not going through the sphincter, we just do a sphincterotomy, fistulotomy and come out, it will heal in say 15 days. We don't need to do laser for that, even now. So fistula with long tract, where we have to cut a lot of tissue. Yes, there is a very big role. Any fistula which crosses the sphincter, maybe internal sphincter, external sphincter, then yes, there is a big role for laser. If there is these fistulas are associated with inflammatory bowel disease, very commonly seen with Crohn's disease. There we have a great fear of doing an open surgery, fistulotomy or fistulectomy, because those wounds will not heal. There this laser is very, very helpful because we don't create major wounds. Another important point is anterior fistulas in females, because there the sphincter muscle is very thin. If we damage the sphincter muscle, then the incontinence will be there. Even uterine prolapse in elderly age will be there because the whole of the perineum gets very relaxed. So for anterior fistulas in females, these lasers are very important. Complex or high fistulas where we have multiple secondary tracts, if delineated with MRI, then we can just burn those secondary tracts with this laser. We need not take down all the tracts. And any patient who has weak sphincters, the only problem with using laser is what? We have to do a MRI fistulogram. So that cost has to be added, because MRI fistulogram, if we don't have any roadmap in front of us. Once we have a good MRI fistulogram, we have a roadmap. Yes, this is how the fistula is traveling, and this is where we have to burn, or if there are any secondary tracts or horseshoe tracts, we can see. There are many cases where there are only intersphincteric abscess. The tract goes and ends in a abscess in between the two sphincters. So those are the areas where the MRI helps us. Contraindications, if there is a large abscess cavity. The large abscess cavity cannot be addressed with laser. We have to drain it. So that is important. And any small tract which we can just do a fistula, we don't need to do a laser in those cases. Those are the two main contraindications of not doing laser. This I have already told you. Use 360 degree here. So the results, yes, the results again vary a lot. Today, the results are much better than 84%. We get up to comparable results as up to 95% of success rate. If judiciously, if the cases are selected judiciously, if you have a good MRI histogram and you use laser very nicely, then we get up to 95% good results. But there is still very high recurrence rate because it's not being used very nicely in all settings. So, case selection, if I am a learner, I should select my cases where there is not, it's not a high complex fistula, it's a straight track probably. And just to learn, I should learn how to burn the track, how much to burn the track. That's very important because you have to give time. I am using laser, I will finish my surgery in 5 minutes. If I have that mentality, all my cases will go. Even using laser, while doing a fistula, I take around 40 minutes as of today. So, 10 to 15 minutes goes to addressing the central disease, that is the open surgery which we do, taking out the internal opening, closing it very nicely. And then another 20 to 25 minutes goes just to burn the track. We have to curate it out first very nicely so that all the disease tissues comes up. And then we have to irrigate very nicely with the normal saline again to take out the disease thing, and then we have to use laser. Once I have used laser, again I curate it out to see if anything is still remaining. Then again reintroduce the laser end. Previously we had an instrument called BAF. It's a video assisted fistula surgery which had come into vogue, but it was not very successful because it was being used alone. Today, I have access to this instrument in one institute where I do. So, I use those for all fistulas to see whether my tract has burned very nicely or not. So, if you can take a look into it, that adds to your success rate. Yes, confirmation, it adds to your success rate also. So, if you have access to a video scope, then you should use it.
Is it an ultrasound probe?
No, it's basically just like we use in laparoscopic telescope. It's a very thin scope, which many places I have also used this cystoscopes which they use. We don't have anything which I just put in a cystoscope. If my tract is wide enough to allow it, I use the cystoscope through it and see whether my things are clear or not. So if you can see, it's much more better. You are much more sure that yes, you have done a good job. Your results will be good.
Robotic treatment?
Robotic treatment for these has not yet come. Has not yet come. Maybe anyone can use robot for anything. So next we come to our last topic, that is pyramidal sinus. Pyramidal sinus is a problem which usually occurs in young mobile patients, and it is a big trouble for them because it affects their movements to a large extent. So basically what we have been doing till now, we excise the whole disease process and then either leave it open or we cover it up using some flap or the other. Whatever we do, the patient needs to stay out of work for at least 3 to 4 weeks, needs dressings. So that is something which we have been able to overcome using laser. These are the different types of here. Any opening in the midline, basically that is the primary sinus which occurs, and then underneath it there is infection and we get secondary ports, secondary openings on the lateral side of the midline. Either side, we can get in either side, we can get multiple openings. So basically what we do in this in pyramidal sinus, to be successful, we should always try to see, we should have a video assisted scope inside. Otherwise, recurrence rate is going to be very high, because even if we leave one single strand of hair inside, it is going to be. So you have to be very sure that you have taken out all the hairs from inside. So that is why the video scope is very important. If you don't have a VAP, we can just put in a cystoscope thing. We can use a ureteroscope thing. Whatever is available in the OT, we can put in a small scope and see. So initially we curate the whole tract very nicely to try to take out all the disease procedures, few hair fibers, whatever are there outside. We irrigate very nicely. These central pits which you are seeing, the primary pits, those are punched out first using a skin biopsy forceps, or we get punch forceps also for this. So we take out the primary pit tract with those things. So the primary pit tracts are taken care of with those punch biopsy forceps itself. And with that, then we can irrigate very nicely. Once the pits are slightly wider, we can irrigate very nicely, and we can take out all the debris and everything through it. We can even send it for biopsy. Very sorry, my videos are not playing, otherwise we would have seen. So once the tract is very nicely cleaned, we again reconfirm it by putting in the scope once, whether we have cleaned everything or not. Till we are not very sure, we keep on cleaning by curating and irrigating. Those are the procedures which we usually do to clean it up. And once we are sure, yes, we have cleaned it very nicely, then we pass this laser probe. Again, the 360 radial fiber is used through the secondary pit to the distal end of the sinus, and then gradually, slowly we burn it up, the whole tract. So again, the same procedure is again repeated here. Once again we curate, irrigate, and then again reburn. So this procedure is common as for fistula and for pyramidal sinus. And the secondary opening is slightly excised from the outside, so that we get a big opening, slightly bigger opening, through which we can keep on irrigating in the post-operative period. So post-operatively, we are left with only these 3 or 4 openings, small openings. We don't have a big wound. We don't have any major dressing to do. Just we can every day we have to just irrigate with normal saline and syringe. Whatever is there, it will come out, and the tract will heal in around 2 to 3 weeks time. The patient can move around from the very next day. There is no restriction for his movement. He can go to work also. If he goes to work, he can just put a small single gauge dressing and walk out. So that is the biggest advantage of laparoscopy. These are the punch biopsy forceps which I was telling you about. This is the basic way how we do it. First we punch the primary forceps, primary pits, take it out, then we curate the whole thing. That is the video scope which we are seeing. This is how we get the tissue for biopsy, and then we keep on irrigating. Once we are confident that everything, the next video is showing that it's a clean cavity, then we introduce the laser fiber and burn it. So coming to the end, basically the difference between traditional and laser procedures, traditional surgeries are still very helpful. Anything with what we do has to be compared with traditional surgery. The success rate or failure rate is always compared to traditional surgeries. So traditional surgeries, the pain level is very high, the hospital stay is long, the wound care is very long and very painful also, and there is a risk of sphincter injury. In laser procedure, the same things, the pain level is very low, can be done in daytime, but most of my cases, except for fissure, I always keep the patient overnight, so that the patient is more comfortable when he goes home. And the minimal or no wound care is required, as in piles there is no wound care, in fissure there is no wound care. Yes, there is wound care of fistula and pyramidal sinus. Wound care means it's only simple irrigation, that's all what is to be done. And practically there is no risk for sphincter damage. Now coming to when to refer the patient to a laser proctologist. Any patient who wants to return to work very fast should be considered for laser. Any patient who has a lot of pain, fear for pain, has to be considered for laser. Recurrent fistulas or complex fistulas have to be considered for laser. Young patients with disease who want to go back to work again have to be considered for laser. To conclude, laser technology in proctology represents a move towards functional preservation. Actually, now there are articles which are coming up that preserving the hemorrhoidal mass helps a lot because our rectum also acts like a drain for the distal end of the colon. It can differentiate between passage of gas, liquid stool and solid stool. So for that, these anal cushions where the piles develop, those are very important. If we can preserve that, then this sensation will be much more controlled. So the concept of preserving these hemorrhoidal mass cushions are now coming into very important, are now coming into big role. So that is how we basically keep the functional integrity of the rectum. We are no longer just cutting out the problem, but using light energy to seal and heal, and it provides a much higher quality of life for our patients. Thank you. Any questions?
Irrigation is considered
What
that
is
is
rectal cancer? Is there a role in rectal cancer?
Probably no.
there is no
No
of
cancer. Conservative surgery in cancer.
Only
Basically,
conservative surgery.
there is some role. If you are asking me, I will tell you something. What we call TAMIS is a procedure where we do local control of the laser of the disease if it's in a very early stage. Yes, there we can definitely use laser to control the cutting part in a very concise way. We definitely can use, but I have no experience of it. I am not using it.
So another thing is out of proctology, but we know if you go back to our first year of anatomy, the internal and external anal sphincters are typically oriented. We know everybody. So many patients come with ischiorectal abscess or perianal abscess. So it involves, we have to be very careful about the sphincter in those operations also. So has laser got any role in this type of operation? It is not related to proctology, but it is
Perianal
periproctology.
abscess is definitely a part of proctology, but I have avoided abscess here. Abscess is very much actually first part what you have to do. We have to drain the abscess. So if you are lucky to get a patient where this abscess has not ruptured, most of our patients who come to me, they have already ruptured. So it's always there is an opening quite away from the anal rectum. The basic concept of training an abscess is it should be trained as close as possible to the anal opening, so that later on when a fistula develops, it will be a small fistula. If we have an opening away from the anal canal, we get a large fistula. So all the abscesses we have to keep in mind which develop are coming from inside the rectum. They are coming from these anal glands. So they always have a small fistula tract which is traveling through the sphincter. Maybe only internal sphincter, or in case of ischiorectal abscess, both internal and external. So if you can identify the fistula tract, you can do the surgery in the same sitting. In all abscess cavities, what we do is we put in some amount of methylene fluid and see if it is coming out from the rectum inside or not. If we can identify the internal opening, we should try to burn the fistula tract, take care of the internal opening just like a fistula. So there will be a bigger success rate. We will not get the recurrent fistula in those cases. If we cannot see the internal opening because the patient is diseased, is septic, we do not venture very much to be looking out the interfacial. If we can easily identify it, we should address it in the same.
MRI should be done in abscess also.
Yes, If possible, yes, because that will again delineate this your fistula tract. The success rate of funding the fistula, addressing the whole disease in same sitting will be very high.
And the TB is very common in our country. So it's very common here. So we get recurrent fistula tract. What I see the surgeons, they become very bothered about recurrent fistulas. So any therapy of tuberculosis prior and post operation or anything like that?
Definitely.
Or any biopsy or anything?
Basically, when a fistula patient comes to us and if we don't know it is a tuberculosis, in histopathology, if the biopsy results come that yes, he has tuberculosis, then he has to be put on anti-tubercular therapy as per our food regime, whatever we follow here, food drug and then 3 drug, whatever.
Same regime.
Same regime, but it has to be for a prolonged period, minimum 9 months to 12 months. We cannot do a 6 months therapy for this because chances of recurrence is very high. And yes, if there is a recurrence in these cases, if we have a slight doubt that it could be tubercular, then we should just do a biopsy and send it before doing a surgery.
Routinely biopsy should be done.
Yes, all cases. All cases you should always
In
do a biopsy.
tuberculosis patient, the previously horseshoe-shaped fistulectomy is done to remove the.
That depends on your fistula tract, whatever tract is there. We have to address everything. In tuberculosis, there are multiple external openings most of the time. The internal openings are in 99.9% cases single. From there, the tract travels in different areas. So, internal opening, if we can address the internal opening very nicely, any disease like tuberculosis or Crohn's, actually the central area is not very healthy. So, if we try to address that, it becomes a big which will not leave anything. So, we try to avoid that. In those cases, this laser is very important. We just burn the fistula tract and if possible, just close the internal instead of excising, just close the internal. That too, we have to identify whether the tissue is friable or not. If it is not friable, we just close the internal. The recurrence rate will be very less. If you cannot close the internal opening, yes, the recurrence rate will be there, but you have avoided the patient from suffering. You have not done a fistulectomy or fistulotomy, you have not damaged the sphincter, you have just burned the tract. Patient will be alright for a few months at least. By that time, if it is tubercular, then anti-tubercular drugs will take into effect. When we do a second surgery, we will be 100% successful.
Thank you, sir.
What do you do in case of recurrence of the disease? Again, you go for laser.
Post laser.
After recurrence.
Yes, it is advisable if your MRI tract, MRI is showing a definite tract, very nicely delineated, it is always advisable to do a re-laser.
Very close externally recurrence is more and success rate is very low. In that situation, fistula, I am telling you, perianal abscess leading to fistula, but close to the very external sphincter. And how to do it?
See, for fistula, the main thing is the central disease. If I can address the central disease successfully, recurrence will not be there. Later on, whatever the lateral part, it may be supralevator, it may be infralevator, it may be extra sphincter, it doesn't matter. If I take care of the internal disease and separate the tract from the internal disease, recurrence will not be there. There can be localized abscess formation if the tract is left. So that tract has to be gone. Very interesting.
Thank you, sir, for your nice discussion. I request Dr. Rajesh Barasia, our consultant in critical care unit, chief, to say something about this program. And I request Dr. Taposh Rai MS for the next call.
Okay, firstly I must thank Dr. Barasia for his excellent presentation. It was a brilliant talk, but when I heard about the topic for the first time, I thought it's a very sensitive topic, ladies and gentlemen. Because it's a laser in a perianal area. It's a very sensitive topic, but he has dealt it very well. And I think he was bold enough to address all the issues very well in a language we understand. Actually, this anal problem, the pain in the longest place, it's a long-standing problem. and we have seen people suffering silently for ages until there was some light at the end of the anal canal, and the light came in form of the laser, and that was very useful, and it was entertaining. What I gather from this talk is a minimally invasive surgery which is quick to recover, less pain, less complications, but there are other research and evidence to come, and time will prove
Time will prove.
how it does, and time will say whether it's a science or whether it's a marketing evidence. Okay, but it is it's a luxury to know that in spite of having a pain in the wrongest place, we have got a solution that is in place. Thank you.
Thank you, sir. Then I will request I will request Dr. Tapas Kumar Rai. And তুমি বসো না 5 মিনিট। Hand over this small memento. Our youngest surgeon, grand surgeon, who
Dr. Barasia, Iskandar Laser, Proctology very nicely, but laser should be given in right person in right place. Don't use laser, I think, without training. It will cause disaster. Okay. In wrong hands, don't use laser.
Okay,
If
thank
you
you.
don't know, if you don't have proper training, you will
Thank you.